We will get Good afternoon, everyone. Thank you all so much for being here today and joining us, which is likely during your lunch hour. So we appreciate your time. I'm Laura Kriswicki. I'm a program director here at CFPIC, and I'm excited to be here today as we learn about opportunities to maximize Medi-Cal services and review a toolkit that will host some decision support tools for you to consider as you learn and look to maximize CalAIM in your county. Before we get started, I just wanted to start off by thanking some of our partners. CWDA has been a really wonderful sponsor and supporter of this work, and we are thankful for their collaboration from not just CWDA, but also the Public Works Alliance, who is sharing their expertise with all of us today. And just a few quick housekeeping notes. We are recording today's brown bag session and we'll host the video on our CFPIC website. We will drop that link in the chat. On the website, you will find previous CalAIM brown bag sessions as we host them monthly, and along with an array of tool and resources for you to use as you support CalAIM implementation, again, in your county. We will also ask for a quick survey at the end of the brown bag just to get some feedback from you and also hear about what some upcoming topics or hot topics that you would like to see at the monthly CalAIM brown bag sessions. So I want to go ahead and introduce you to our facilitator today. Sarah Arnquist is an experienced healthcare executive with a background in Medicaid policy and behavioral health systems. Sarah supported top officials in the state's Medicaid programs and collaborated with international healthcare leaders to study success models of large-scale healthcare delivery. So thank you so much, Sarah, and I will turn it over to you.
Thank you, Laura. I'm going to now share my screen and try to figure out how I'm like looking at you and sharing my screen because I'm on two monitors. All right. Um, so today, as Laura said, we're going to walk through a toolkit of various resources, and our goals are to um, help you know about or make you aware of the different resources that have been put together to support child welfare agencies related to your decision making around Medi-Cal enrollment for children and youth in foster care, to review some resources related to connecting children to enhanced care management and other Medi-Cal, other Medi-Cal benefits, and get tips to use the materials for your staff trainings or to update workflows so that you can continue to maximize Medi-Cal services for children and families. This is the content of the different toolkit materials that we're going to look through. Really, the webinar structure is going to be kind of stopping and pausing on each one of these different resources and orienting you to it, showing you where it is, and so that you can take it back and use it in your department as you like. That you'll get access to the slides that have links embedded within it. I also think that you'll many of these links will get posted on the CFPIC website, and so you can find all of it there. Many of these materials were developed in collaboration with multiple counties and were reviewed by counties before they were made available. And so want to express sincere appreciation for the collaboration from all of the county participants, many of whom are on this call today. We know that you're very busy and that you took time out to help improve these materials is appreciated. So these first set of documents that we want to orient you to are really about understanding Medi-Cal managed care and the decision-making process between enrolling in managed care versus fee-for-service. Not all counties have a choice about that, but 21 counties do have a choice. And so this first document here is an issue brief that really it's more of a long narrative, as you can see, that kind of explains what is Medi-Cal managed care, what is Medi-Cal fee for service, what are the who's mandatory to go into managed care, who's not mandatory. How does that break down by, across the state? What are the differences at a high level between the two systems? And what might be some of the new benefits to being in managed care that aren't available in fee for service. And so that's what this document is. So maybe it's a good resource for that you send out the link to different staff to orient them to if you have managers who might want to read it. And there are some more like sort of step-by-step guides toward the end. The next resource is a at a glance side by side. So if you really want to see, what we did was just to take the different sort of components of Medi-Cal and, here's what's available in fee for service. Here's what this means for managed care. And so you can scroll down and see different areas related to geography, provider of choice, network adequacy, and then some of the sort of supports around appointment assistance or transportation assistance, language interpretation, the different benefits that are available, and again, provides this side by side comparison. The big difference here is that between, you can see right on this page, these CalAIM services, so enhanced care management, transitional care services, and community supports, not available in fee for service. The only way to access them is through managed care. Um, and then there's a series of FAQs as well. I'm not going to pull it up, but you all know what FAQs are. Um, we then just recently did a deeper dive into out of county placements. We know that this is an area that does seem to cause kind of extra amount of confusion when it comes to what to do with Medi-Cal enrollment. And so we have a resource that's dedicated just to out of county placements. I think this was just posted last week. And tried to really do a simple sort of guide of if you have a county who's starting or a child who's in a single plan or county organized health system, county moving to a multi-plan optional county, sort of what does that mean? Then we did multi-plan optional county to multi-plan optional county, sort of all the different scenarios. Added some steps on what to do to sort of the consideration of changes in enrollment in that out-of-county placement. And then added some FAQs. This is an area of a lot of complexity. And so as you read this and look at it, if anybody comes, identifies something that might benefit from extra clarification or maybe didn't get totally right, please provide that feedback because we'd like to continue to improve upon this and try to I guess, cut through some of the noise and confusion that does exist around what happens when kids move between counties. Um, One additional resource that we have is around a decision support tool. So this tool, we created this in PowerPoint version. And the reason we did that is that we wanted you counties to be able to take it and modify it for their own situation. I really want to give a lot of credit to Fresno County and to Justin Johnson in particular for helping develop this and sort of workshop this with their staff. And so we tried to do this in language that social workers would understand and your line staff could understand. And the format idea is that it's a sort of printable document with front or back or something that they could post up in their cubicle or put into their electronic resources and could reference and as a quick guide when they need a reminder of the different workflows. And so again, this is in a PowerPoint version and you can customize it. I will show, it's going to download actually now, isn't it? So here's what it looks like as a PowerPoint. I'm not going to go through every single step, although I can, once I orient you to, if we want to go back to any of these and like deep dive into them, I certainly can. Um, but what it also does is show the different managed care plans across the top. So again, this was sort of mock-up created for Fresno County. And so there was Anthem, Calviva, HealthNet, and Kaiser are the three plan options in Fresno. And then we did get answers from these plans to these questions. So these are the actual answers based from the health plans, like how do social workers check pediatrician assignments? How do foster parents check pediatrician assignments or make a change? How do social workers or foster parents check which pediatricians have availability? Is there a point of contact to troubleshoot issues? And so this is what each plan said to do. How do social workers refer children or families to enhanced care management services? Again, these were responses and directions provided by each health plan. And so if these health plans are in your county, you can take this and you might want to verify with them, but it should generally be the same correct answer. And then perhaps use this as a template for the other health plans to get similar responses if you believe that these are common questions that your social workers would be asking of managed care as well. The other parts of um, the decision tree are really sort of key considerations for all task areas about leveraging Medi-Cal. Um, this is starting from the standpoint of, you know, kind of a preference to keep the child enrolled in managed care unless it will disrupt access to primary care or specialist providers. They are likely to change placements frequently, moving between counties, and managed care plan enrollment may disrupt their access to needed services, or a resource parent says that managed care creates a barrier to accessing services and strongly prefers fee for service. Um, then different steps um, around, again, this is intended to be for social workers or for line staff to like think through what they should do to determine or basically look up and research related to the Medi-Cal status, who to consult with, um, different considerations for Medi-Cal enrollment, and then what to document in CWS CMS. And then finally, if they needed to make Medi-Cal enrollment updates. One key point here is that no decision is final. So if you do choose to enroll a foster child in managed care, you can disenroll them at any time. And you can even do emergency disenrollment. So no decision is final, which we heard is an important message for social workers who might be scared of making or recommending the wrong choice. And then we also tried to organize this by different sort of points of your continuum or of your structure. So knowing that you often have different teams who are working on like one part of a case, and that team doesn't necessarily know the end-to-end process. And so this page is around sort of the intake and emergency response workers. What should they consider and what should they do? So this page is for them. And then this next page is around the post-removal and ongoing management areas. Again, the link to this is on this Public Works Alliance page that we can put in the chat, and also will be available on this PowerPoint side. So actually, I'll just put this in the chat right now before I forget.
I already put it in the chat,
Oh,
Sarah.
perfect. Sorry, I'm not able to monitor the chat while I'm.
No worries.
Okay. All right. So what's coming next? So we've continued to hear different areas of confusion or that could just benefit from more deep dives as we talk to more and more counties. And so a few of the next resources upcoming that the Public Works Alliance team we'll be developing is a training deck around checking Medi-Cal eligibility in meds. There seems to be, it's not always intuitive, and so a sort of a guide to that. ECM and consent, so a guidance for specific scenarios to improve coordination at the individual and population levels, who can share what information, when, with whom. It's extra, as you all know, this is your daily lives, but it's extra consent in child welfare has extra layers of complexity, and that complexity is definitely new to a lot of providers in the healthcare and on the managed care side. And so this paper is maybe not just for child welfare audiences, but also the larger healthcare space to understand the context of child welfare and consent. And then metrics that matter. So really thinking about as you execute these managed care or execute MOUs with managed care plans, a data sharing is a really big part of that. But what to do with that data? You know, if you get the data, how are you going to use it to improve outcomes? What format should it come in, and things like that. So this is just I guess a teaser of future things that the Public Works Alliance team hopes to work on and will hope to share with you all as it becomes available. All right, I'm going to pivot away now from the sort of Medi-Cal enrollment toolkit aspects and move more into enhanced care management. And I'm going to share a tool that was developed by Full Circle Health Network. So several months ago, I think still probably in late 2024, several people on this call who represented child welfare agencies were in a meeting with CWDA and Baljeet and some others talking about enhanced care management. And somebody from a county, I can't remember who it was, but actually asked this question, like, is there a theory of change behind enhanced care management? And we took that back and we asked DHCS and we asked around, and there actually wasn't one. And so Full Circle Health Network, which is a hub supporting community-based organizations, many of whom have a lot of experience in child welfare, took it on to create a theory of change for enhanced care management, specifically for child welfare involved youth, children, and families. So what is a theory of change and how to use it? It can be a communication and planning tool to create a map of a logical sequence of steps leading to the desired outcomes and try to align stakeholders around that process. Can clarify goals and assumptions. So to make explicit what outcomes are we trying to achieve and what needs to happen to get to them. A blueprint for action can facilitate evaluation. So how do we measure, is enhanced care management working? Many of the measurements around enhanced care management that are being led by managed care plans or even at the state level really are focused on adult health, chronic health management. So, is your blood pressure being managed? Are you taking your medications regularly? Are you not going to the emergency room as much? Are you using less healthcare? Are you costing less? Those metrics don't necessarily apply to children very well, and they don't necessarily apply to children in child welfare. And so what are the measures that matter to the child welfare population that enhanced care management might address? It can help drive system change and then improve decision making. So here is the theory of change. It's pretty little text. I'm not going to read it in detail. If we want to do it, if we have time, we can come back to this, but just to orient you to it. So what are the different inputs that are necessary? So county child welfare agencies are listed here around sort of defining referral pathways with managed care plans, educating staff on the direction of those referral pathways, and getting the data on the child welfare case, providing the data on the case status, the managed care plans, Again, this is from Full Circle standpoint, so would contract with Full Circle, define referral pathways, link the data to the shared population and have population health data. Full Circle would have a network of providers. The providers would have culturally competent, knowledgeable staff. The children and families would provide consent, and community partners would have knowledge on enhanced care management. And then it goes into what activities is everybody doing. So at the top, there's infrastructure between managed care plans and child welfare agencies. There'd be data sharing or data use agreements between them. They develop processes to identify which children and families should be getting ECM and implement referral pathways, including consent, have agreed upon streamlined referral pathways, build awareness among staff, and provide training and support to referrers. Full Circle would do various activities, and providers would deliver the enhanced care management. So then short-term outcomes, immediate-term outcomes, and long-term outcomes. Short-term, we kind of categorize these as access, utilization, and engagement, and then the child and family experience, sort of calling that out as a defined part of important outcomes, the provider experience, and then the partnership and sustainability. From a short-term standpoint, increasing referrals to enhanced care management, increasing engagement of those who are referred. So they're actually saying, yes, I want to do this. And that families are engaged early in services. From a family experience, that children and family are receiving services from providers who reflect them or reflect their community, know their community, and are trauma informed. They trust the ECM providers and are comfortable seeking services. They're satisfied with the ease of connecting, and they feel respected and are supported by providers delivering the care. The providers have a smooth onboarding experience and are supported in delivering their capacity. They understand program expectations and have tools to execute. And in terms of partnerships and sustainability, that there's effective and mutually beneficial collaboration between child welfare agency, managed care plans, providers, and community resources. For intermediate outcomes, really just building on the short-term ones, but hopefully that you see ECM becomes a familiar tool in the child welfare prevention plans. So, as you're even early on in the differential response, or as early as possible in cases like looking to ECM to support children and families, ECM increases their children and families' access to timely services, and there's adequate engagement in care plans. That children and family continue to have positive experiences, but also achieve their child welfare case goals. Like we called that out here, that enhanced care management hopefully can help make that happen. Educating TAE and non-minor dependents to navigate their health plan. So as non-minor dependents are transitioning out of foster care, that they know how to access their healthcare services. And they feel supported, families feel supported after the child welfare case ends. So one thing about enhanced care management is that it can continue for 6 months or potentially longer after child welfare closes its case, so that it can support, it can be an aftercare strategy, frankly. Providers continue to have good job satisfaction, and in terms of sustainability, social workers feel they have extra support from families and recommend ECM to each other as a helpful tool. So thinking that enhanced care management could potentially sort of buttress social workers and public health nurses in achieving their goals, that they have another resource available to them to help refer families out to. And thus they have improved job satisfaction. Longer term outcomes, overall, ECM would help prevent system involvement because there's increased success of family maintenance, speed up family reunification, goals and support non-minor dependent transitions to independence. There's improvements in health quality, such as greater compliance with child visits and immunizations, and improvements in health equity, so reduced access and outcome disparities by race and ethnicity. Over the child and families experience a greater trust in Medi-Cal system, reduced trauma impact of system involvement, and improved connections to support systems long term. There's greater diversity in managed care plan networks due to increased CBO participation, would be part of the provider experience. And then in terms of partnerships and sustainability, that the child welfare agencies would leverage all available Medi-Cal services for children and families, and managed care plans provide priority pathways for system-involved families. This is ambitious, but putting it all on one page hopefully does kind of achieve some of these, why we have a theory of change. And again, if there is feedback from anybody on this, Full Circle is open to that feedback. This is sort of a soft launch or early draft of this, but also might help you at the child welfare agencies think through, how do you orient your agency around enhanced care management, and how might it help achieve your goals in this effort of working with managed care plans, and be a communication tool to different parts and teams and managers across your agency. I'm going to shift a little bit to enhanced care management referral approaches. There was a paper by the RAND Corporation at the end of 2024 that looked at what has been successful in linking clients or Medi-Cal beneficiaries to enhanced care management. And essentially, what they found, and I don't think any of you will find this particularly surprising, but that when there were cold call outreaches from the managed care plans or from providers to beneficiaries, had a very low enrollment rate. What was most effective was when a provider who already had a trusting relationship with a beneficiary talk to that beneficiary about enhanced care management and what it could offer them, and ask them to enroll, and then basically sent that referral up to the managed care plan for approval. And a greater proportion of those individuals enrolled in enhanced care management. This referral doesn't necessarily have to come from a provider, but from some trusted person who's basically priming the beneficiary and what enhanced care management is a much more effective method to get them enrolled. So Full Circle created a kind of a step-by-step process for what that might look like for child welfare, where maybe the social worker at the initial referral would tell a parent or caregiver about enhanced care management and would then seek permission to send a referral to a local provider. So I think what's important here is actually, rather than sending it to the health plan, it's going to the provider, and then would use a closed loop referral system to email the agency or request services. Basically, once they send it to the provider, confirm that the provider got the referral and the provider is going to do something with it. So the provider would receive that referral, would connect with the parent, or the caregiver, or they would explain what enhanced care management is, and then hopefully get consent to participate. The idea is that the parent or the individual is more likely to give that consent because they know what this is, and it's not just coming out of the blue. The provider would collect the different information needed for the managed care plan referral or authorization and submit that. So what's important here is not putting the burden of collecting this referral, like 6-page referral form from that on the child welfare agency, but shifting that sort of responsibility for collecting that information to the providers. And then the provider would do the intake process and assessment process and notify the county of what happened. The managed care plan would authorize and process that request within 5 days. There is now a presumptive authorization process. And so this, technically, the provider could start initiating services right away. And then they would deliver enhanced care management. So these are the different steps, right? So do an assessment, create a care plan with permission, communicate with existing service providers, such as the public health nurse, the pediatrician, or the behavioral health provider, help make medical, behavioral, dental appointments, arrange transportation, link the family to concrete supports, and an option to also potentially link a parent or caregiver to other supports, such as community health workers. So this is one example of a referral approach. There is a county, and I'm going to put Dr. Liao from LA on the spot a little bit, where has implemented basically that referral workflow in one of their regional offices. So this is the Glendora office workflow from Los Angeles, where, and I'll just go through it super quickly, and Dr. Liao, feel free to go off mute and add anything that you would like to add. But the children's social worker would receive a list of eligible children and youth, would conduct outreach to the caregiver and discuss the youth eligibility and benefits of enhanced care management. If the caregiver agrees to make a referral, the social worker would continue to support and then have them fill out, they would complete an interest form and an 802, which is a consent form, and send that to the list of identified ECM providers in the area. So they've got a short list of ECM providers that know that they might get these referrals, and they're then sending them with this interest form and the consent form to those providers directly, and then would contact optionally the or would facilitate a consult call with the family, and then again, like I said, send that form via email. Also send it back to this sort of centralized number or email address within the county. Dr. Liao, anything you'd like to add, or should I just keep going?
Yeah, thank you, Sarah. So the only other thing I'd like to add is that, as kids come into the system, then that list of eligible children and youth changes. And so the Glendora office has basically come up with a, um, a, a slightly modified step for number one in terms of checking the eligibility of the kids themselves through the one of the DHCS websites. That if you place in the client index number or with the date of birth or social security number, then that can check and see whether the child has managed care plan or not. Since regular access to that kind of information isn't available to our social workers. And if there are any kids who they think that would benefit from ECM, then they can go ahead and talk that through either with our office or with their supervisor.
Thank you. And if anyone has any questions, feel free to put them in the chat, and at the end we can open it up for discussion as well. We've only got a few more slides to go through. So here's just screenshots of the different of the consent form and the interest form that they're using at the that I just mentioned they're using in Los Angeles. And then here are screenshots of Full Circle's consent forms. You'll get links to these. Peter's been sending them out as well, but so you can, they're pretty basic consent forms. I think this is the one of the last resources. So another piece of feedback that we have heard from many counties is that social workers really, if you're going to start training about enhanced care management and Medi-Cal, need to lead with, well, how is this going to impact the families that I'm working with? Like, how are kids going to benefit from this? How are the families going to benefit from this? And what does this look like in practice? And so these are a variety of different case studies for child welfare that are the different statuses. So there's a family reunification case study, there's a permanent placement case study, there's a family maintenance case study, there's a transitional age youth case study and a probation case study. And you can access these and download these and use them in your trainings. That's why they were created, and modify them as you like. But to help sort of bring enhanced care management to life using real life scenarios. So most of these scenarios were real cases or sort of modified versions of real cases, and so should resonate with your staff. And you can access them. They're all posted here, free to use, available for you to use as you as could benefit the different trainings that you're putting together. And again, what we've heard is maybe lead with a case study and get people excited before you potentially go into less exciting details about Medi-Cal and managed care versus fee for service. So just to recap, there's a variety of different tools available to you around Medi-Cal enrollment that can inform your policy or practice changes, but also help line staff make their decisions about what's best in the best interest of the child. There's different resources for enhanced care management connections. So the logic model that you could take, or the theory of change, referral workflow examples, and consent examples that you can use and leverage. And then staff trainings, customize any of these materials to update your trainings or to inform your workflows and staff training. That is the end of our slides. Happy to go back to any slides or to field any questions or discussion.
Go ahead.
Hi. Have there been any conversations with the Department of Healthcare Services in terms of feedback of ECM and the outcomes with kids?
I personally have not had conversations with DHCS, and I don't think the Public Works Alliance team has. Uh, and to my knowledge, there's not been anything more formally sort of put out by the department around outcomes for children and youth. I don't know if that answers your question. So maybe there's an opportunity there. And that's partially why Full Circle developed the theory of change, is to sort of spark that conversation.
Yeah, I think it'd be great if that conversation could be raised, because the data that's collected on the DHCS ECM webpage is just enrollment, and that's it. And so that's not a very compelling argument for a lot of providers. And yeah, thank you.
Yeah, and I just want to add what's been kind of monitored at this point is just utilization, right? So enrollment, is the service being utilized? And based on latest quarterly data, the children and youth population is still underutilized for ECM. And so definitely this is a great time to educate counties on how to get children and youth involved in child welfare into these benefits and services. I think you raise a good point in that, okay, enrollment has happened, but what's next, right? Are we seeing improvements? And that's where the MOU is a vehicle for that conversation with your managed care plans in regards to what data are you going to track and monitor together. That will then hopefully feed up to DHCS and better inform their dashboards as well. I know we have some other partners on the call. If anybody else wants to add any information on this. Well, I think, this is an opportunity to have an open discussion about the content that Sarah provided. And thank you so much, Sarah. Great information, really helping, I think, counties to kind of conceptualize what does this actually look like, right? Beyond just the MOU execution, but what does it mean to take advantage of these benefits and services, but also starting with what does it mean to enroll foster youth in the Medi-Cal managed care plans, some of the challenges that we've all heard coming from counties about this process. And so these guides and toolkits definitely help. I think will be a great asset to counties to help process this at the local level. This is also an opportunity for any county to raise some best practices that you're seeing in your relationship building with your managed care plans. Any questions you have about the MOU or anything else related to any of this? Yeah, Edward.
Um, if the counties are beginning this work, I think it's a good idea to include ECM providers in a presentation to your social workers, because they're the providers that they hopefully have already worked with and will hear about real life examples. And so that's been helpful for our pilot here in LA.
Thank you. And I see a comment in the chat. In Shasta County, adults have been able to access many ECM services while they are receiving SUD treatment. Yeah. SUD is a population of focus under ECM with specialty mental health services. So thinking about, children and youth and families that you serve, even outside of opening referrals and cases. How do we get families into these services so that they don't need to come into the system, don't need child welfare involvement? So they may not fit under the child welfare population of focus, but there's other populations of focus that they definitely would fit under as well. All right, I see a question from Diana. Question for LA and other counties. Are you piloting ECM access with any certain populations like TAY, and how is that going?
So this is LA again. So children with special medical needs is a population that we are enrolling as well too. And then for TAY, I actually would like all TAY to be enrolled before they exit child welfare. That hasn't happened yet, but that conversation is up and coming.
Any other counties where you're beginning to make referrals to ECM? What has your experience been with certain populations in child welfare like TAY? Or maybe you're still trying to figure out the managed care plan process. Like, all right. Well, I'm going to hand it back to CFPIC to wrap this up. So Peter or Laura?
Yes, well, thank you everyone for joining us today. There was another question in the chat about the presentation. It is being recorded and will be available on our CFPIC website, along with all of the tools and resources that we went over today. We dropped the link to the website there in the chat. Just give us a couple of days on the video. Hopefully by the end of the week, you will find it on there. In addition, we do have a quick survey that we're asking you to take. We'd love to hear from you and any other ideas you have about monthly brown bag sessions, on how we can support your CalAIM implementation. Thank you so much. Have a great day.
Have a great day, everyone. Thanks.